Can you see me? Hello, everyone. Um, Hello, I'm Dr. Wiggins. How are you guys? I want to see your faces, but that's okay. There, okay. Well, at least I can see me, so I'm not going crazy. This is so fun. So, thank you guys so much for coming today. In this world of COVID, this is actually the first Zoom meeting that I am hosting. So I'm kind of figuring it all out. This definitely would not have happened without my husband. He is the tech guy in our family, so he has got this whole thing set up, and I am really excited to do this. So I will get started. I don't know if we're waiting for a few more, but we can go ahead and get started. Definitely put your questions in as I'm talking. Put your questions into the Q&A, and then I will get to those at the end. And I want to talk about what you want to hear about. So if I didn't cover it, don't be afraid to ask. This is definitely an informal time where I just want to be of help to you. So thank you so much for coming. Again, a big shout out to my husband. This would not have happened without him. And today we're going to talk about if a total or partial knee replacement is right for you. Let's see. All right, so as I said, today we talk about you. We talk about your goals, your limitations. We'll teach you a little bit about your anatomy and what is happening when you get arthritis. We'll talk about some treatment options ranging from conservative to surgical. We always start low and go high. And then we'll talk about how we make up your plan. And all of my plans are specific to my patients. You know, I don't believe in a one size fits all type of medicine. And then at the very end, we'll get to some questions. So I have no disclosures during this talk. But first, a little about me. I am a wife, as I've mentioned. I'm a mom of two boys. They are crazy. We have a 5-year-old and a 15-month-old, so the house is a lot of fun. I am a surgeon. I'm a board certified orthopedic surgeon here in Cincinnati. And just a little plug, I am the only female surgeon in Cincinnati who is trained and certified on Mako SmartRobotics. So that is pretty cool. I was an athlete and a patient myself. I was a soccer player in college. I've had 4 major knee surgeries. So I have a unique perspective in the sense that I've been through the medical training, but I've also been the patient. I've been on the other side of the table. And I know what it's like to be looking at your surgeon with 1,000 questions that you just can't think of, which is why I think little interactions like this are so important. So first, I just want to start with a little case study. I think it's nice to meet patients who are just like you and me. So I'd like you to meet one of my favorite patients, Cathy. She is a 71-year-old woman who enjoys walking 2 to 3 miles a day with her husband. She enjoys playing with her grandkids. And over the last 6 months, she's had to limit those activities. She's had to kind of take her walks down to a mile at night. She was finding excuses to get out of social events because she thought she would limit the group. She was finding herself sitting more at family events instead of playing with her grandkids. So she came to my office to talk about what we could do to help her get back to the life that she knew she was capable of living. And so understanding your goals is actually a huge part of going to the doctor. You know, there are things that your doctor needs to know and that you need to know about yourself so we can help get you exactly what you want. I frequently say that I am in the expectation management business. If my surgery or my treatment options can't get you to where you want to be, then you're going to be very disappointed. So before we start with any treatment options, we need to understand our goals, and then we need to realistically set our expectations. So what are your goals? Cathy's goals were very clear. She wanted to walk 3+ miles. She wanted to have less pain. She wanted to chase her grandkids and maximize her social opportunities. But maybe your goals are different. Maybe your goals are running a marathon. And then we have to really talk about if that's possible with a knee replacement. You know, maybe you want to get back into hiking the Grand Canyon, or maybe it's just yoga and Pilates or golf. These are all wonderful things. Maybe it's just simply to be pain-free, and that's great. But knowing where you are, it helps to start that conversation. So the next step is just to understand your limitations. It was Cathy's knee pain that was keeping her from the life that she enjoyed. And so I always pose this question, people say, well, when is it time for me to get a knee replacement? When is it time for me to start doing something about my knee pain? Well, when is it affecting your life? When do you start to worry? Are you starting to worry now? My knee, if I do this walk, then my knee's going to hurt for 2 or 3 days. Is it worth it? Is your knee pain keeping you up at night? Maybe it's time to start thinking about doing something. Are you having to use a cane or a walker now because of your knee pain? It might be time to think about it. But then also critically look at what else is limiting you from doing the activities that you want to do. Do you have other medical problems that are keeping you from walking? Maybe your weight is creeping up and that's stopping you from exercise. Maybe you're a smoker and have shortness of breath. Maybe you're a diabetic. All of these play a significant role in the life you're able to do, and they are important. So here, just talking about your anatomy a little bit. The knee joint is a hinge joint. It's made up of the femur, the tibia, and the kneecap. So shin bone down here, thigh bone up here, and the patella in the middle. Between the two bones, we have the meniscus. That's the blue pads here that you see. Those, I say that they're the cushion or the shock absorbers to the knee. That's like the brake pad of the knee that helps to cushion and distribute your body weight. You also have 4 ligaments in the knee. The ACL and the PCL are the ones in the middle. Your cruciate ligaments, you hear of athletes injuring their ACL. That's the main stabilizer to the knee. And then you have 2 collateral ligaments on either side. Surrounding the knee, you have cartilage on the bone, the white cartilage that you see here. That's the same white cartilage you see on the end of a chicken bone. As you get arthritis, that starts to deteriorate. And then you have joint fluid surrounding the knee. And as we get arthritis, that joint fluid starts to deteriorate. Fun fact, us women actually lose the cartilage under our kneecap faster than men. So we're a little bit more prone to certain types of arthritis throughout the body, and arthritis under the kneecap is one thing that women are more commonly going to get. So this is what happens as you develop arthritis. You lose that natural cushion in the knee. You see on one picture here, you have a lot of space between the bones. The white articular cartilage looks good. The meniscus are nice and plump. They're helping, to support the knee and cushion it. You have normal joint space. As we get arthritis, we lose that space from the femur to the shin bone. And part of that means that meniscus then gets squished and macerated. So a lot of people end up with degenerative meniscus tears. So that meniscus is no longer acting as the shock absorber. Instead, it's just getting worn between the bones. Next, the cartilage at the end of the bone starts to wear out, and you can see that white blue is fading away, and you're starting to see the bone underneath it. When that starts to happen, when you start to get the friction between the bone, and we start to develop bone spurs, and this is this extra bone that's on the side that shouldn't be there. And that is very rough and thick. So people with arthritis start to feel grinding and stiffness. All that grinding causes inflammation. The inflammation causes pain. Pain causes weakness. Weakness causes stiffness. And the cycle just continues. The more pain you have, the more weakness you have, the more you're going to be sitting, the more pain, the stiffness, the weakness. It just becomes a vicious cycle. You'll also see some swelling with arthritis. The body's trying to lubricate the joint and kind of break the cycle, but it can't do a great job once we get that arthritis. So now that we understand what it looks like, in a cartoon character, this is what it looks like in real life. And these are Cathy's x-rays. When she came to see me, you can see she has very little joint space. It's completely gone on the outside here and on the inside of the other knee. She has these osteophytes. These are these bone spurs out here. She has lost that meniscus. She's lost that cartilage. And her main complaint, she was stiff. She was achy. That's because of all of the arthritic changes. So now we start to talk about our treatment options. There are 2 questions to ask. What can we do? And then what do you want to do? Because we can do a lot of things, but sometimes we can't for all people. There are things that you you need to know, there might be some allergies you have that will limit what we're able to do. You might be a diabetic, and that might limit the cortisone injections that we could provide. You might have a fear of needles, and so injections are just not an option, and that is fine. You might not have a very strong family support, so surgery and the recovery might be difficult. And weight and smoking, and other contributing factors might limit what we're able to do surgically, just because it raises the complication rates. So as we talk about treatment options, most people have done at least these first two before they come and see me. I think we've all tried the ice, the heat, we're taking ibuprofen, maybe we've even taken naproxen or Aleve. They last a little bit longer. Maybe our primary care doctors have given us meloxicam or diclofenac, some of the stronger anti-inflammatories, and those are great. That is exactly the best place to start with arthritis. Remember, we talked about arthritis is an inflammatory condition, so we want to stop the inflammation. That's why the NSAIDs, ibuprofen, the Aleves, things like that, those are anti-inflammatories. They stop the inflammation. They help that arthritis feel better. There are a lot of supplements that you can start taking over the counter as well. Glucosamine and chondroitin sulfate. Vitamin D is very good for joint health, vitamin D and vitamin C. We've seen some anecdotal evidence that CBD oils, rubbing that on the inflamed joint, can be very helpful as well. So moving from medications, then we talk about injections. So now we're moving upstream. We start with these least invasive options and then get into the more invasive options. And that includes injections. There's a few different types. The first is a cortisone injection. That's the steroid injection. That is a steroid, so it's a hormone. It stops that inflammation in your knee. So it can be very helpful to quickly help your arthritis feel better, but it lasts for a short amount of time, usually about 3 months or so. And then, those symptoms start to creep back up. And some people can't get cortisone injections, so we have to have some other options. The next step I typically do is the visco injections, and those go by a few different names. Some call them the gel shots, some call them the rooster comb shots, some call them the cushion shots. But basically, it's the same joint fluid that you initially had, but you lose as you get arthritis. So it's hyaluronic acid. We make it in a lab. We inject it into the knee. It helps to lubricate the joint, take away some of that stiffness, puts that healthy joint fluid back in. And it actually stimulates your body to make the right type of joint fluid, that hyaluronic acid. So those can be very helpful, and they last longer than the cortisone injections. So they last usually 6 to 9 months or so. Along the same lines, we have these biologic injections, which are gaining a lot of traction lately, and rightfully so. There's two main types. There's PRP injections, and then what most people are calling stem cell injections. PRP injections are very helpful for mild to moderate arthritis. That is where you come to the office, we take your blood and spin it down, and we get the platelets out. We spin down those platelets and get them into the most concentrated form that we can. We then inject those platelets back into your knee because they have a lot of growth factors to it. These growth factors incite a positive inflammatory response in the body and recruit all of these healing cells to the joint that we injected, and helps to heal the arthritis and helps to heal that inflammation. Very, very helpful for arthritis, for tendonitis, things like this. But it does take that extra step of, it's a more invasive procedure. We're drawing blood, we're spinning it down, we're putting it back in. Stem cells work in a similar fashion. Stem cells are precursor cells, so they don't have an identity yet. So we are taking these stem cells either from somewhere else in your body or from a lab, and we are injecting those into your knee. Those cells, they're basic cells, so they have the potential to grow into new tissue and hopefully heal some of that damaged joint surface. Both the PRP and the stem cell injections are not covered by any insurance plans. That's the most common question I get. They are not covered by insurance plans. So we usually talk about, the risks and benefits and whatnot. More conservative treatment options include bracing and physical therapy. With arthritis, there's more friction at the joint. That friction causes more inflammation, causes more pain. So using a brace and adding stability to the knee can help decrease the friction, decrease the inflammation. Physical therapy is also very helpful. The stronger your muscles are surrounding your knee, the less force will go through the joint, the more force that those muscles can take. So physical therapy, keeping your range of motion, your stability, your balance, and your strength is huge for having a well-functioning knee before, during, and after surgery. And then, of course, weight loss is huge. It's my favorite stat of all time. For every 1 pound you lose, you take 4 pounds of pressure off of your knees. So I know a lot of people say, oh, I got to lose 60, 70 pounds. Don't even worry about that. Don't start with the big numbers. Just start with 5 pounds because it'll make a huge difference. All right, we've talked about all of the more conservative treatment options. So now we'll get into why you're really here, to talk a little bit about the surgical options, the partial and the total knee replacements. I'll skip over talking about knee scopes. If we have, if we want to address that later, we can. But we'll talk about the partial knee replacement and the total knee replacement here, and what I'm doing in Cincinnati. So a partial knee replacement is appropriate in some patients. They have some pretty narrow indications. It's mainly our young, very active, healthy patients that have arthritis only in one spot, sometimes two, but usually one spot of the knee. So arthritis just under the kneecap, arthritis just on the inside, the medial compartment of the knee, arthritis just on the lateral compartment of the knee. If that's the case, if you have arthritis just in one specific area, the rest of the knee looks beautiful, healthy cartilage, the ligaments are intact around the knee, then it makes sense to only replace where you have arthritis. It doesn't make sense to replace an entire knee and healthy parts of the knee if only one part has disease. I love doing partial knee replacements when it's appropriate because I'm always thinking 2 and 3 and 4 steps ahead, So if you do a partial knee replacement now when you're young and healthy and when it's indicated, then later on down the road, we have a lot of bone left to work with when and if you would need to be converted to a total knee. And that's one of the main reasons why I use robotics when I replace my knees, because with the robotic system, I can take out only as much bone as I need to, and I can leave the rest of the bone for another surgery down the road. So here is what they look like once they're completed. The partial knee replacement, again, is just that single compartment. And then the full knee replacement, that means you had arthritis throughout the entire knee, and we took all of that white cartilage out. We took out the meniscus, we took out at least one of the cruciate ligaments, and we put in the total knee. So the femur and the tibia are replaced, and then there's a plastic piece in between. All right, so now that we know a little bit of the groundwork here, we consider you. And we talk, specifically when you come to see me, we talk about your goals, we look at your x-rays, we've done all of the treatment options, we've determined that you are a candidate for a partial or a total knee replacement. So then what happens? What happens after that? In my mind, that's when the real fun begins, because now we get to develop a surgery and a plan specific for you. With using these Mako SmartRobotics, the knee replacements are patient-specific, they're personalized, they're reproducible, they're accurate, they're bone-sparing. It has been game-changing with total knee arthroplasty. So what we would do before surgery is we would get a CT scan, and that just gives me a good picture of your knee in a 3D representation. We put that CT scan into the computer, and it builds a 3D model of your knee. Based on that 3D model, I can decide, okay, we need to take more bone here, less bone here. We need to rotate this piece, to make it more anatomic. And I'm doing this all before surgery, before we even get you on the OR table. We have a pretty good plan of what we're going to do. Then we get you on the table, we make the incisions, we balance the knee a little bit more throughout with range of motion. We calibrate one last time with the robot, and then we execute the plan. We take off only as much bone as needed, and the Mako ensures that I stay within the plan that we have put together. So here is a little video showing you how it works. Giving me the thumbs up. Really
Let's take a look at how it works. It begins with a CT scan of the knee joint. A CT scan is a series of x-rays taken at different angles that can help surgeons see things that they can't typically see with an x-ray alone. The CT scan data is used to generate a 3D virtual model of the patient's unique anatomy. This virtual model is loaded into the Mako system software and is used to create the personalized preoperative plan. Prior to surgery, the surgeon reviews the plan size and placement of the implant, and if necessary, modifies the preoperative plan in order to better position the implant to the patient's unique anatomy. During surgery, the surgeon locates points on the knee in order to register the anatomy in the Mako system. This process establishes the relationship between the patient's actual anatomy in the operating room and the 3D model that was used during the planning process. This step helps ensure the procedure is executed to plan. Once the anatomy is registered to the 3D model, the surgeon has the flexibility to modify the preoperative plan based on their assessment of the patient's anatomy and range of motion. Then, the surgeon guides the robotic arm to remove the arthritic bone and cartilage from the knee. A virtual boundary provides tactile resistance to prevent the surgeon from removing more than just the arthritic bone identified in the preoperative plan. And visual cues, shown in green, appear on screen to show how much bone to remove. Collectively, these cues help the surgeon stay on the preoperative surgical plan. With the diseased bone gone, a knee implant is inserted into the joint space. And once the surgeon is comfortable with the knee's movement, it's off to the recovery room to begin the journey towards strengthening the knee joint.
The Mako total knee patients have a lower pain score, they have quicker recoveries. And in this world of COVID, we are doing less and less in the hospital to keep our patients safe. So this has been a game changer. We're now actually able to do these total and partial knee replacements on an outpatient basis. It's been pretty incredible. So back to Cathy. We did a total knee replacement on her with the help of the Mako SmartRobotic technology. She had her surgery first thing in the morning, went home the same day. She started physical therapy with home health the next day. So surgery on Friday, therapy on Saturday. She started outpatient physical therapy over the next 1 to 2 weeks. It's pretty typical for patients. And she relied on her very strong family support for the first 2 weeks. I do think everyone needs someone with them for a couple weeks after surgery. And then at our 1 month visit, she was back playing with her grandkids, and then she was working back up to walking 1 to 2 miles already. She was just doing phenomenal. And these are her post-op x-rays at that first visit. So that is it. And this, I'll just leave this up. This is my office information. How you can schedule. The online process for scheduling is very, very easy. So yeah, and then I'll take some questions. All right, I'll just start at the top and go down. All right, so this question, I'll read them out loud and then I'll answer them. What is the approximate cost for PRP and stem cell treatment, as insurance does not cover this? Great question. Each practice has different costs. For ours, it's about $700 for one PRP injection. The stem cell treatments are anywhere from $1,000 to $2,000, depending on what we're doing and where. So yeah, good question. And the PRP, I should mention, they last about 9 months to a year. Oh, yes. And my husband, thank God for my husband. He's saying that you can use your HSA and flex spending accounts absolutely to pay for those PRP and stem cell injections. Let's see, next question. How long would it take from the first appointment to surgery date? That just depends on your surgeon. We usually need about 4 to 6 weeks to get the CT scan for the Mako. There's a lot of doctor's appointments that you need to go to. We do a physical therapy visit beforehand to make sure that you have the right tools to be strong enough before, during, and after surgery. You go to see your primary care doctor. There's a few steps that we need to take to make sure that you are optimized to have the best possible outcome. So typically about 4 to 6 weeks from that first appointment to surgery. And then how long is recovery? That also depends on each patient. Everyone's a little bit different. Using the Mako, with that Mako technology, I'm seeing patients getting back to their activities, in 4 to 6 weeks, and really doing quite well. And then therapy lasts as long as you need it to last. If you've met your goals at 4 to 6 weeks, then you're discharged and you're back to life. If you still, have bigger goals or lagging behind a little bit, that's fine too. Some people do therapy for 3 months. And then big picture, it really takes a full year to recover from a knee replacement. But most people are back doing their daily activities, very little pain at 4 to 6 weeks to 3 months. Is this procedure covered by insurance? As far as the Mako, yes, most insurance companies do cover robotics. Sorry, I'm reading. Yes, most insurances do cover the robotics, the robotic portion of the surgery. Let's see, are all patients candidate for Mako? Most are candidates for Mako, yes. And which hospitals do you operate at? The Mako, I do my Mako procedures at the Wellington Specialty Surgery Center, which is attached to our Eastgate office on Ferguson. That would be where we would do the outpatient total knee. You would go home that day. I also operate at Jewish. We have a Mako there, and at Mercy Anderson. And is there an age limit for a partial knee? No. Are you saying an older age range? No, there's not on either end. But again, very patient specific. We would talk about your goals. Certainly, the older you get, the more likely it is that you're going to have arthritis in the other compartments of the knee. So it generally makes sense just to go ahead and do one knee replacement and do the full, because we don't want to come back, as you age, to do the other one. And then as far as a young patient, we don't want to do a knee replacement too soon. So if we're, the longer we wait, obviously the better for anything, but it all depends. Can you describe the interaction between the doctor and Stryker? Yeah, so as far as the manufacturer, the company, I work with my reps very closely. They help ensure that the imaging centers know the correct protocols, and then the manufacturer, Stryker reps, and I work together before surgery to manipulate that 3D model. And we're going through it together, and I'm saying, well, let's tweak this, let's tweak that, and then they're helping me just with the tech side of moving it all around. And how do you? Yeah, so exactly. So we kind of work together, and then the beauty of those reps, they all work with many different surgeons. So they also come back and say, hey, you know what? I saw somebody tweaked this, did that, worked well. So I kind of gain their knowledge as they gain their knowledge. So we do work closely together. A typical hospital stay, if we do the total or the partial knee in the hospital, it's an overnight stay. You'll either go home that same day from recovery, or you'll stay overnight. And then the next day we get you home with home therapy starting. And like I said, a strong family support. Yeah, so the next one, is it better to get the gel shots, or should I get surgery while I am relatively younger and better able to recover? Yeah, great question. And I really would need to understand, your whole story and what you're getting back to, your age and everything. I kind of say if the gel shots are working, keep doing them. because if you're still young and active and healthy, you're going to hopefully stay that way. And then we can always do the surgery when you need to. So I think if something is working, keep doing it. And when the gel shops, when they stop working, then now's the time to start thinking about surgery. Will I be able to run again? Yes, you can run with a total knee. I don't encourage you to do marathons because you will wear it out. It's the plastic polyethylene piece in the middle of the plastic between the femur and the tibia implants. And so the more wear and tear on the knee, eventually it does wear out. The longevity of knee replacements now is 20 plus years, especially with robotic technology. But the more stress, the high impact activities you put on it, obviously the faster it'll wear out, as with anything. So can you run? Yes. I want you to stay active. I would encourage you not to do, long distance running and a lot of high impact activities. So what type of anesthesia will I have? That also depends on a couple of different things. We typically do them with a general anesthetic and nerve block. So you get a nerve block to the leg and throughout the incision. As I'm operating, I do this, and then that can minimize the pain, for the first few days. The other option is to get a spinal and then and also get the nerve blocks. As patients are going home now, the general anesthetic, you just come out of that a little bit sooner. You can get ready with therapy a little bit sooner. You get up and walking. The spinal takes a few hours to wear off. So we're leaning more towards the general anesthetic with the nerve blocks so we can get you going on your new knee. How big is the incision? As big as it needs to be. Skin heals side to side. That's what I always say, usually about the length of my hand. But if it needs to be bigger, then we make it bigger. If it can be smaller, we'll make it smaller. It's very interesting. We went through a whole minimally invasive stage where people were making smaller incisions, but then I think we were pulling the tissues apart more to see what we needed to see, and it was causing more pain afterwards. So we make a slightly bigger incision to do what we need to do with the robot, but it's a less invasive surgery because I don't have to manipulate the tissues as much, and the robot is so specific. So for a relatively active male, 45 to 55 years old, are there any activity limitations to expect after full recovery from the Mako partial knee? No, the partial knee is great. That is essentially a resurfacing. I leave all of your ligaments intact. The only thing I take is the femur and the tibia bone and the meniscus in between that one compartment. And so your knee feels the most natural with the partial knee. I wouldn't give you really any limitations. The only thing I would say is sometimes just with the incision, patients don't like to kneel on their knee. It doesn't feel good, with the incision there. So if somebody does do a lot of kneeling and crawling, I would just counsel them on that beforehand. But we want to do these knee replacements to get you back to doing the things that you want to do. Does Mako assist if and when you are using limb salvage products versus a more typical partial or full replacement? So I think you're talking about revision surgeries. Technically, no. That would be off-label, I believe, for the Mako, but we do help, it does help with the preoperative planning and whatnot. It has been suggested that I do the Euflexa gel injections. Perfect. Is that worth trying before surgery? Absolutely. Yeah, absolutely. Because why not? It can be very helpful. And if you have this moderate arthritis and the gel injections get you 6 to 9 months and you're able to enjoy your life and then do a knee replacement the next year, I think that's great. But on the flip side of that coin, if you're not able to enjoy your life for the next year, I don't want you sitting around just watching the clock waiting for a knee replacement. So I think it's worth a try depending on what your x-rays look like and how much joint space you have left. Certainly if it's bone on bone, then I don't think it's going to help. But if somebody has suggested that you do it, they say you have, some joint space left and it would be helpful. Absolutely. I would try it. And you know what, you can always do surgery in a few months if it doesn't work. how is it decided to have surgery at the hospital or the outpatient center? Great question. Yeah, and that's just, again, a conversation that I have with you and your family. It really depends on if you're able to go home, if you have the family support to bring you home that day, and it depends on your medical comorbidities. You know, if you're young and healthy and active and you've got a great family that can come and be there with you, then home is the best place to be. That's where you're going to heal the best. And then some patients would prefer an overnight stay, and that's completely fine. 23 hours is approved through insurance, so we can do that as well. How long does a knee replacement last? About 20 plus years. So the technology is getting better and better. Are there any exercises I should do to prepare before surgery? Absolutely. The stronger you are before surgery, the easier your recovery is going to be after surgery. So prior to surgery, I reference this before you do a prehab session. So I send you to meet with my therapist or the therapist that you'll be working with afterwards, and you learn the exercises, you learn what to expect, what your goals are, and then yeah, you start doing those exercises before surgery. Perfect. Would I be able to walk half marathons? Absolutely. Yes. Yes. Let's see. How long after knee replacement can I drive? So if it is the right knee, then 4 to 6 weeks. I was saying 6 weeks always because that's kind of the literature that we have. But now with Mako, people are just getting better faster. So now I've moved it to about 4 weeks. And if it's your left knee that we're replacing, still about 4 weeks, but it really just depends on when you're comfortably able to sit, you know, in the car. Let's see. And then how long are you off work? That really depends on your job. If you have a desk job and your pain is well controlled, you could get back, you know, within a month or so, 4 to 6 weeks. We want to make sure that incision is well healed. If you're working from home, maybe sooner. If you have, you know, a pretty physical job, construction, manual labor, things like that, then I would plan at least 3 months, and we can always send you back sooner. Are all robotic knees Mako? No, there are a couple different robotic systems out there. Mako is one that I use. I'm actually certified in 2. And so, but yeah, not all robotic knees are Mako. After recovery, would I be able to kneel and do yoga? Yes, absolutely. You can do yoga. The kneeling just feels different. I don't want you to do a lot of kneeling because we do resurface the kneecap. We don't want to injure that. And then most people say it's uncomfortable to kneel because you have an incision right down the middle of the knee now. You have metal and plastic under the kneecap. So every now and then I get patients that say, I can kneel, I feel great. I don't, you know, it feels no different. And I say, okay, fine, go for it. Do it. It feels good. But I will say most patients say it just feels weird. They don't love it. And so they figure out a different way to modify that. But absolutely do yoga and then modify child's pose. Please. Okay. Is there a way to talk with Stryker directly so they can think, develop the basic hardware options and then refer surgeons who work with a lot of revisions? No, I don't think so. I don't think so. But I'm like trying to think, like, do I have my rep? Yeah, I can certainly follow up with my Stryker reps and definitely get back with you. And yeah, we can reach out to you directly after to make sure that you do get the help that you need with this, because it sounds like, you know, it'll be it'll be a big revision. Yeah. So yeah, do we have his contact info? Okay, good.
Email address.
Perfect. We have your email address. Check into my tech support. We have your email address. We will definitely reach out to you and see how we can help. Do I come to any Northern Kentucky hospitals? Not at this time. No. Maybe in the future. I don't know. Let's see. How long does it take to schedule an appointment at your office? We have walk-ins available Monday through Friday at our Eastgate office. You won't necessarily be seen by me. You know, we split up who does the walk-ins, but so that is always available, Monday through Friday walk-ins. And then scheduling online, you can typically schedule same day or next day with me. I'm in the office currently 4 days a week. I have 1 day at Anderson, 2 days at Eastgate, 1 day at the Westchester Clinic. You can schedule directly online. You know, when you hit send, you're not waiting for a call back. You have scheduled, you want that 10 o'clock appointment, it's open, it's yours. So I can see you pretty much same day or the next day. And then if you call the 232 bone, my assistants will always fit you in. So, and then how long is the wait for surgery if I'm ready? Again, yeah, about 4 to 6 weeks just for all of the logistics. And then will this webinar be available for review? Absolutely. We have been recording it. Yes, and we will keep posting it. Yes, anything else? That's it. Thank you, my husband. Thank you guys so much for listening. This was so fun. I hope it was helpful. It's definitely helpful for me to see your questions. And so then for the next talk, I can make sure that these are addressed throughout the talk as well, and then we can keep building. So we have emails. Would it be okay if we, what?
We're going to send a follow-up email tomorrow anyway. If you have questions, they can
Oh, I see. Gotcha. My husband. Yes. So we will be sending out a follow-up email tomorrow. If you have further questions, just send them our way. In addition, if you would like me to reach out to you directly, please let me know via email, and then you and I can have a phone conversation, or we can get you scheduled at the office. Whatever you need to do. I am always happy to answer questions and to talk more. I know it's a big deal. It's a big surgery. It's not to be taken lightly. So I definitely want you to get all the information you need before you jump into it. And that's it. I'm so excited. I really appreciate all of the interaction. Thank you so much. And I hope to see some of you soon, if not all of you.